folders, I've printed out the individual slides so you can follow along. And there's a few activities that will use your black folders for in this session. So we'll get started. So what we're going to do is troubleshoot some cannula issues. So we're going to have a look at dressing changes and VIP scores. Then we're going to have a look at cannula size and how it relates to the flow of fluids. We're going to have a play and the function that we use it for. There's a couple of activities with that. What I want you to take from the session this afternoon is I want you to be able to look at a cannula and know when a dressing needs to be changed and change it, and to accurately assign VIP scores. I want you to know how the size of a cannula and the flow rate relate to each other, and identify and select the best size cannula for the purpose we're using it for. So, cannula dressing changes, do we do it well?
No.
I've seen some.
When we change them, we do.
Yeah. Yeah.
It's what happens when you come back the next day and see the tape that's been put over the barn or anything else.
Oh my God, throw the bloody tape away. So this will be printed off in your black folder too if you want to pull it out and have a look. What's doing here?
Being held down by tape away.
Yeah.
The insertion so it's not covered.
Yeah. What about the bung that's on it? Did anyone say that before?
No.
It's a gripper?
It shouldn't be there.
Yeah.
No.
So in our facilities with peripheral cannulas, they should be needleless access devices. So we've got lots of portals for infection there. What about this one? What's the similarities there?
Yeah. They haven't secured it before they put the film over the top.
Yeah.
They haven't got the right bum on it.
Yeah.
Doesn't look labelled.
No.
Yeah.
That was the point of the last one too. There's no date on that.
Lifting.
Yeah. Yeah. And again, it's a needle access port. I don't really want to be going at people all usual. And yeah, if you just went and did a little tug on the end of that, or the patient did a little tap in the bathroom, you know where that's going to end up. So if you had that on your own kid in the hospital, you would be happy. And what about this one? Bananas. This is the worst case scenario I've seen, but do not see the insertion site at all.
Absolutely. And they put the dressing on the wrong way.
So, interestingly, with the dressing, we're going to do a little activity with dressing changes in a minute. I could not find it very clear in the paediatric setting how to put on a cannula dressing, but for adults, there's no actual policy on how to do it, which I found very interesting. So I'll be looking to see what you all do. So yeah, we can't see the insertion point, so what's the point? It's dirty. Do you guys really use those extension ports? Tell me.
Not
really.
A lot, because it saves you manipulating the cannula close to. Oh, that's how I was taught.
Yeah.
For ward cannulation, to put on an extension tube because it stops you manipulating at almost at the level where the cannula is inserted.
Yeah.
And that was the primary reason. So supposedly less risk of introducing infection, less risk of disrupting the dressing.
Yeah.
And less trauma.
Yeah, and I can see we're going to watch a little bit about that, and I can see how that would relate.
I can understand it with the elderly.
Yeah.
Kids.
Kids are a different story. Kids are very specific about what we have to do and how we do it.
There's a lot of staff that say, oh, it's policy. Your ID should have that. So it must be a rumour if it isn't. You know what I mean?
So I've done a bloody good read of that policy. Anyway, so So instead of, if you have a takeaway point for today, I'm just kind of curious about the extension line. Can you please just change the dressing and not stick another bit of tape on it? And we'll have a go at that. I know we're not very good at it. I know nobody has time to do anything anymore. But yeah, if this was your nan,
Yeah.
you'd be like, I'm not happy
And
with
you've
that.
got to reinforce it, you go under the bun, not over it, because everybody believes from that tape is going to the bun.
I tape the hook up, but not really to there, I tape it up here, just so it doesn't, I tether it.
Yeah, yeah. Feathering's always good.
Yeah, I have been guilty of trying to tape a person back on.
Yeah,
So
we've all
it's
done
like
it. We've all done it.
Yeah.
We're time poor, and sometimes.
Hello, Miss Leanne.
Hello, come on in.
Welcome.
We just started without you.
That's okay, I'll just up.
Pull the chair over here, Dylan. Sorry, we had a bit of a change of locale, so
I've been everywhere now.
we're living on the edge. So if you can't see this, the folders have got all the slides in that. So we're just having a chat about cannula dressing and how we can do better. Alright, so speaking of the policy, I was having a massive read off so you guys didn't have to. It's a very specific point about dressings in section 5.7. And down the bottom here it says your transparent, semi-permeable, self-adhesive polyurethane dressing should be changed every 7 days or sooner if it is no longer intact, evidence of inflammation, or is moist. We're all guilty of it. I think it's something we could do a bit better. Particularly in ED, I've found if there's an IV pump, I think I did it the other night with you, Janine, that's pumping and alarming and occluding, have a look at your dressing. Maybe a dressing change can stop. If it's moist under there, there's also a section in here where you can use sterile gauze to help soak up some of that. But there's very strict conditions about so every 24 to 48 hours that gauze needs to be changed under the dressing. Alright, so there's nothing I can show you in here in a simulation that's really going to reflect how difficult it is to change a cannula on a little old lady with fragile skin, dry skin, or patients that are anticoagulated or being on steroids long term. If it's moist, it's tricky. So I think we used to have the Smith and Nephew anti-adhesive swab. I think in ED I'm seeing some of this brand anti-adhesive swab. It's always a good idea to have some of those on your cannula trolley. So I'm going to show you a little video in a minute. But you always want to pull the dressing, you want to hold onto your bung firmly to secure it and anchor it, and you want to pull the dressing in towards where that cannula is going into the skin and not away from it. Be gentle and be patient with your patient. And hope it's not a granny with a sign that's going to sulk you while you're trying to do it.
Or a hairy old man.
Or a hairy old man. Hopefully someone's been kind, but that's not always the case. Have a look at who's around. Should you accidentally bugger up and pull it out, who else can replace it for you if that happens? Or if you get the dressing off and go, oh, that's rubbish, it needs to come out, I can't leave that there, it's good to know you've got someone on that can replace it. I just want to run through a little activity where I've got these foam simulators, and someone can come up and use Jeffrey, my phlebotomy arm. He's new and he believes I'm so proud of him. He's a bit rough to cannulate. I think he might be a bit too rough for people that are learning. So basically I want you to show me how you change a cannula dressing. So one person pull the cannula off without pulling the cannula out, and another person put on the cannula and talk through why they're doing it like that. Okay. There's a couple of cannula dressings on the table. Feel free to crack the 3M ones.
Yeah, don't feel off.
Don't feel bad.
We've only got these to use.
Yeah. I'm going to pull pull this off. So you just want to come in towards the insertion point to help prevent it coming out. Janine's bloody all over it. Lovely. Okay. Ruth's on it. Does anyone want to come and play with Jeffrey? Sure. He's sitting up here all by himself.
I can see my point roll.
Gloves on.
Thanks, Jay.
Dressing open.
Yeah. Do they have steri strips? No, I saw the impregnated ones and went, no. A couple of older ones here too. I've got an old school one to go if you. Oh yeah, that's slightly better. How to play. You can pull them off and.
Oh, okay.
They're probably, they're probably not fit for purpose.
You've got a thin one? Oh, there they are.
And I was watching online. So I guess the main points are
I'm definitely not doing it how I'll do it on Thursday because I know it's not.
I want to make sure nothing can fit in under that dressing. That's the whole point of it. And I don't want to be able to come along and pinch your head like that. Because there's nothing worse than if you've got a person that's been really difficult to cannulate, and if you don't secure it properly, you lose it. And there's other complications as well.
I'm often tempted to go
It's
there.
bad now. Like I said, there's no policy for how to apply cannula dressing.
I was afraid it by many
Yeah. So if you pinch that with your, just the bung.
I do that and try to do one over the time.
Beautiful. How you going, Jen?
I'm done, Steve. This is what I've done. I've put the primary dressing over the cannula so I can see the insertion site. I've put the secondary part over the bung and the cap so that if there's any issue you can take that off and change the bung or whatever, and then I put the date sticker there. And I had a question about that.
Yeah.
Because I didn't put this cannula in, I've just changed the dressing. What's going on the date sticker? The original date?
So we'll talk about that. That's an excellent question as well.
Okay guys, I'm just going to talk you through a quick dressing change and how to apply the IV dressing the way I like it. There's no standard application that I could find for IV dressings in adults, so I'm just going to show you the way that I find it most effective to do. So to begin with, I perform hand hygiene, and ideally I'd be wearing gloves. It's important to anchor the bung and to start picking up the dressing from the edges. Now whenever you're pulling on the dressing, you want to be moving towards the incision site here, and that'll avoid any tugging and dislodging of the cannula where you can. You can also use your Unisolve or any adhesive swipes to help that dressing come away, particularly from dry or fragile skin. So you just move around the dressing, pulling towards that incision site, same on the other side, towards, and then back here. And use your anti-adhesive swab to lift, back towards the incision site, all while maintaining your firm hold on the bung and the position of the cannula. Okay. You can use your adhesive swipe to get rid of your underlying steri-strip. And again, you want to pull that towards the incision site. Same on the other side. Now you're inspecting the cannula site to ensure that the cannula can actually remain in sight. So you're doing a quick VIP assessment, looking for any redness, bleeding, phlebitis, anything that would indicate that you need to remove the cannula. And then with your chlorhexidine swab or wipe, you're cleaning the side underneath.
And you want to push it down firmly so you don't have any air bubbles or gaps. Pinching, spreading.
And you need to let that air dry.
Okay, so lift your bung up a little bit to get the dressing in and around underneath.
And with your cannula dressing, I like to pull the steri-strips off.
Or entry point for liquids or pathogens under the dressing. And remove the external border.
And again, securing your bung, you want your steri-strip to go over your cannula port. Like to pinch to ensure that the tightness of the bung's there, and actually pushing that steri-strip down to prevent being able to pull the cannula out. And then I get the main non-occlusive dressing. And again, you want the split to come just where the cannula bung sits in the middle. And you want to push it down firmly so you don't have any air bubbles or gaps. Pinching, spreading. It's okay to lift your bung up a little bit to get the dressing in and around underneath. Again, pushing and securing so you've got no access or entry point for liquids or pathogens under the dressing. Then I remove the external border. Then with the final steri-strip, I've seen some people place it underneath the bung to fully secure the dressing underneath. But what I like to do is again put it over the top where the bung and the cannula point connect, and again push down and pinch. And that just gives, I'm giving a good tug on that, and that's just an extra securement point so the cannula can't dislodge. Okay, thanks.
Luckily we don't have people long enough with cannulas for death and sepsis from a device. That's all good. Alright, so other than thank you beautiful, other than the fact that it's convenient for us not to lose the cannula, there's other reasons why securing a cannula is important. So this is what phlebitis looks like. This is what we're, feel free to sample in if you like, guys. I'll edit that out so it looks like it's the lay people here. This is what we're scoring on the VIP score. So this is what it looks like on the inside. Yeah, ouch. Now, infiltration, that's what it looks like. So you're starting, you're getting the phlebitis up on the inside. And think about it, that's going to hurt. That's a bit of plastic rolling around in your vein. So the infiltration is where it's actually rubbed along the inside of the wall of the vein so much that the tube can actually penetrate through it. And changing the dressing, think about fragile skin, moist skin, pressure areas. Who can replace the cannula if you need to, and a VIP score. Alright, so VIPs. So it's the visual infusion phlebitis score. So I think there's some loose leaf where you can see the VIP score a bit easier. So we're going to rate a couple now if you want to pull them out of your folder. Alright, let's watch some VIP. So in the big black folders, there's printouts that you can't see the screen. And have you found your VIP piece of paper?
Yeah.
So here, let's say this is phlebitis. You write down.
Still got an airway, he's coughing.
Beautiful.
Fairly effectively.
So we're seeing redness around the IV site and a bit of swelling. And I'm going to say there's not pain though, because I look closer and it's actually a simulation dummy.
Like it's a score.
Did you say there was
What do
pain?
you think? No, because it's a dummy, it can't. So do you think the VIP is? 2. Anyone think any different? Anyone want to argue? Have you tried it?
Lynn looks compromised. Well, we can't assess pain if they're not, pain,
Yeah,
not
you
feeling
can't talk
pain.
to them. So it's a dummy, so
Yeah.
he doesn't get a pain score. That's what I went with.
Yeah.
So any 2 symptoms, so possible signs and symptoms of phlebitis, redness, swelling, burning sensation, discomfort, discharge, increase in temperature. We've got all those things. That's pretty scary. You
Yeah.
reckon it could have been 3?
It could have been a
Because
thing,
we
because
felt
it
it.
was definitely fresh.
Alright. So when you see any of these things, you should stop the infusion, remove the cannula if you need to, clean your site for infection, talk to your doctor and see if antibiotics are required, monitor the patient's vital signs and document patient condition and management.
I reckon if it wasn't a dummy, they would have pain. And if I
Yeah.
saw that, I'd be replacing that cannula.
Yeah, absolutely.
So,
As a 2, can you still, you reckon? Can you still,
Okay, that looks bad enough.
still,
it says restart.
Why wait till it gets to a 3?
It says restart.
alright. So hold your hand still. Alright, have a look at this one. This is infiltration.
Oh, poor person.
Yeah.
So what do you reckon with the cannula? Warm it, compress and elevate it, came down quite quickly, but as you said, there can be quite adverse outcomes with infiltration. So if we identify redness at the IV site, obvious swelling, and I reckon that's pretty painful.
Yeah.
What do you reckon we give it?
She's complaining of pain.
A 4. Can we give it a 4? So pain on the path of the cannula, redness around the site, swelling,
Do we know whether there's
and a palpable venous cord. So it has to be for a 4, it has to have all of those following signs. And because we're cannula superstars, none of our patients are going to have a VIP score of 4 or 5.
So
She might be getting
we
that from another hospital.
can't feel.
Not to blame the other hospital, but if they've travelled from over the mountains, by the time they get to you,
So that's the difference between a 3 and a 4. You have to have a palpable venous cord and all of the other symptoms. Alright. So treatment for this, the signs and symptoms, little or no flow of the IV infusion or bolus. It's cool to the touch, hard to the touch, swollen and pale. The fluid might be leaking from the infusion site. Pain, tenderness, irritation or burning sensation. So stopping and removing the cannula immediately, elevating the affected extremity, warm compressor to encourage absorption. So did we think of 3?
Yes.
Collectively upon review? Alright, so other factors that contribute to phlebitis or infiltration include the size of the cannula, the location and incorrect stabilisation of the cannula. So we saw that with the cannula taking a right around the vein on the inside there. So we're talking about, does size matter?
Not always.
Depends
what they do.
No comment.
Sorry, to have a little joke there.
So I think the answer is definitely yes.
Yeah.
So I'm passing around this little chart here. Now often we don't play with the cannulas once they're in the patient's skin, so you've got no idea how big they are. So I want you to have a little flick of the 16 and see how firm that is. And then go all the way down to the 24 and just see the difference between the sizes. So for those playing at home, we know the numbers are a bit backwards with cannulas. So the smallest number is a size 16, but that's actually the biggest cannula. And the biggest number, which is a 24, is a baby cannula. Right, so I've got our pretty rainbow coloured ivory fluid charts. I'm just anticipating how messy this is going to be. If we aim for these container size, I'll get some fluid. We're going to time how long it takes to get 100 mils through. Does someone have a stopwatch on their clock? Yeah. So, Rach, you've got a yellow.
Yeah.
I've clipped him off. There's a bluey there if you need him.
Yeah. Oh.
That grey one.
Just the clip, though, and then
Oh, just a quick.
I got the yellow one. All right, let's go. Open. That's all right. So yeah, bigger size, you know, it's going to flow through easier. Looking at grey there. Look at poor little yellow over there.
Oh no, terrible. I'm very dehydrated by the look of this.
Yeah. How are you going with pink, Janine?
Well, I'm going to have to use some gravity.
Oh. So I think the point mainly, yeah, is Leanne's winning because she's got the biggest cannula.
I was just listening to him.
Oh, I love him.
And yeah, Rach is losing because hers is the tiniest.
Oh, I know why.
Come on, yellow. You're letting me down.
You're tiny, Rach. It's not going to help, darling.
I've just left it.
Well, come to the ward, please. We need you.
Yeah, they will retire.
There we go. So grey's about down, grey's out, and you can even see with the bags where we're at.
2 minutes.
You can even see with the bags.
Yeah.
So grey's done.
Yep.
Yeah.
Green.
Green's just about done.
Oh.
Oh, I've got these around the wrong way, Rach.
Oh.
That's okay.
That's okay. I think we get it.
Yeah.
Do now. This is a really, because I'm a kinetic cleaner.
Yeah, me too.
I thought it looked pretty good too.
Me too.
Do you want to tape him in there?
Touching and
Yeah.
All right.
Okay.
I think we agree that size matters. All right, we're all stuck in.
You like blue like me. That's my favourite.
You're welcome to have a seat, darling. You could be there for a while.
it's not going to fall over.
I could, but we'll deal with that.
You will. Oh my God. I know. It's big, guys.
Don't move, right? So when it comes to mils per minute, now there's a couple of different cannula sizes here that we normally don't use in our facility. There are 14 gauge cannulas.
Yeah.
So you can imagine after looking at the 16 gauge how big that'd be. And then how tiny a 26 gauge would be after looking at the yellow one. This cannula that we've got will do a litre in 5.5 minutes.
Wow.
Our green one will do a litre in 11 minutes. Pink one will do 17 minutes for a litre. Blue will do 28 minutes. And a yellow takes 50 minutes. So that's why I don't have you all standing up there waiting, even though we're only doing mini bags. Oh, Rach.
I'm not. It's alright, it's just so that all
You were so, now we know about size and flow. Now, how can we relate that to the cannula function? I think it's really important in cannulas, particularly in ED, we think, oh my God, they're going to have to go for a CT. They need a 18 gauge or we're going to hear from radiology. When they come over to the ward with this massive big cannula in, and it's not cool. So we need to make them a bit more fit for purpose. So thinking about our flow rate, should we expect a blue 22 cannula to give a 500ml bolus? Equally, should we be putting 18 gauge green ones in our whole people? Like we talked about.
But if they put one in, they've gone to CT, I'm not going to rip it out and try to get another one in.
I think we need to think about the patient as well. Like we have a look at those signs of one of the problems with having poorly sized cannulas in vein is the infiltration and the phlebitis isn't as caused by the cannula size. And if we've got a disproportionate cannula size to the vein, those things can happen. So it's something we need to be looking at constantly, and I think that's why they're really drilling in the BIP with this at the moment, because we need to be thinking bigger picture.
I tend to agree with you, though. Like, I'm not particularly if they go to this go to our vein.
Yeah, but say it's now day 2 or 3, you know, that's getting too long. Yeah. If we're not using it.
So these are just some examples of what we use cannulas for. So we've got vesicant fluids like potassium in our cancer patients, for multiple blood products, in CT and imaging, for massive bleeds. That's an example of a PV bleed, I think there. A postpartum hemorrhage, I think this is a baby. Trauma. When we're giving, now would you say peptides is a more sort of irritating antibiotic? Definitely something we dilute. More blue factor. We can always clip them off too. He's done now. You're the last one to finish, Rach.
Oh, no.
Beautiful, darling. You're getting there. Multiple infusions. Little oldies, with little pointy hands. And then other antibiotics that are probably not as harsh. We don't necessarily put in a bag. Alright, so now in our plastic envelopes, there is a puzzle where we allocate the different types of patient groups we have. Sorry, I'm winging it. Beckle. Beat me later. So yeah, I just want to allocate the different patient groups. Here's a bit of blue tape. Very advanced. There's some blue tape to stick them on. Okay. So CT.
Funny, don't they? Asking for 20 lately.
Yep. They get what they get, right?
Yeah.
So what they do and why they're asking for 20 is because have you seen how they give the contrast?
Yeah.
It's a massive push infusion. Lots of infusions. Multiple infusions. Oh, Leanne. You're bringing the team up again, darling. Well done. That was crazy. Yeah, beautiful. Alright, let's have a look. So, what did we put in out of 16? In the biggest cannula, what are we putting through that? Yeah. Pouring it in, yeah. So it's you know, there's no right and wrong answers. I mean, there's some wrong. You definitely will be putting potassium through at 24, but your multiple infusion bags, you know, you might want to put that through at 16 as well. We saw how quickly they flow through.
Yeah.
So okay, there are some wrong answers. Anything else for a 16? Okay, what about an 18? The CT guys have a few there. What have you got down, for example, to put through an 18?
Well, just in case the neighbouring mum goes into like postpartum
Yeah.
or something. You want to have at least an 18.
Oh, gee, legs.
Big because of the push.
Yeah, yeah.
Big with
Like we saw the differences between the grey fluid and the yellow. You could definitely see the difference in that velocity, I guess. Okay guys, what did you put in the 20 gauge section, Leanne?
We had potassium and a CT.
It could go in.
You
It
could go with an 18.
Yeah.
It could, yeah. If you've got an 18, I definitely use it.
Yeah.
They say more than an arm.
Yeah. 22s.
Your pick acid and chemo.
Yeah. Again. Yeah. Mainly, not, sorry, I probably should have specified more clearly. So patients that have had chemo rather than chemotherapy drugs was my point there. So chemotherapy patients would be more likely to have more friable, fragile veins. So I was going more to a smaller size cannula.
Okay.
Yeah.
But I would have thought if they were giving chemo over
Yeah.
a certain period of
I
time,
should
you
have
wanted to have
articulated my point.
Cancer
clearly.
services used to give us a 4 sheet in case they're preventing ED. If they're having what do you call that thing again? No, not the porticap. They're having a symptom where high elevated fever.
Yeah.
So
Like
neutropenia.
febrile neutropenia.
So basically the instruction that we get from them is like only 22 to 24
Yeah.
only. Like
Beautiful.
they grill us if we do.
Yeah.
Still do come in with their little.
Yeah, hopefully they should. So, can we think of any examples that we put a tiny 24 gauge into an adult? So, maybe in cancer patients?
Yeah.
Yeah.
Sometimes it's the only access you've got.
And it comes back to what we're using it for as well. So, other than frail, elderly old people that we might be trickling fluid through, like, and I mean trickling, like Rachel's yellow, and maybe chemotherapy patients, again, what we're using that cannula for in chemotherapy patients, I can't think of another reason why we have a yellow cannula in a patient, unless it was like subcutaneous fluid.
Subcutaneous fluid,
Yeah.
Yeah.
Okay. All right. We're done. Thank you all for coming. Does anyone have any questions? Questions are good. It makes me look good. Makes you sound like you're engaged with an audience.
You just told us so well, there's nothing more we need to know.
Exactly. No, that was very nice.
The flushing technique.
The flushing technique?
Yeah.
You're doing performance reviews.
Wow.
That is it.
All right. So does size matter?
Yes.
It does. Very good.
Rachel.
Oh, dear.
Like I said, there's a big difference between a small glass of wine and a big glass
That's
of wine.
right.
Thank you guys. I'm sorry if you go back out there and the water's falling apart. Thank you for coming. I know that might be a little bit. Is there anything that you
she's good. She's gonna
found
be good.
particularly interesting?
She's going to be working with me on this thing.
Yes.
Yeah.
Just everything, like how to put the thing on. Yeah. It's really good. It's one of my favourite, possibly my favourite thing to do as a registered nurse is cannulating. I love it. I love it when people say you're never going to get a cannula in me and then you can get a cannula.
Yeah. I'm usually challenging
That's like a
something.
challenge.
Yeah, Kate
This
always
is my
says that
party
too.
trick.
She said that
This is my
instead of
party
taking
trick.
blood,
Especially if the other one doesn't get it, hold my
Yeah.
beer.
Oh my God.
Oh, Lauren should be. Lauren's will keep you busy tonight, right?
Yeah.
Funny. He's good
We'll be
people.
right. And I've got a block of chocolate too with her.
Is there not one of
I still
those?
remember that with KBJ, Jimmy.
No, that's
I still remember that with KBJ. She tried one with everything and I'm like, I got
I
one.
might come
You
and
sure?
knock Leanne if you can't find one of those tags.
It's a good feeling.
Oh,
man.
Wow, that was very good. Thank you very much.
Thank you for coming. No problem. I'm going to pack all this shit up.
Yes.
I'm going to go.
Well,
Thank
thank
you
you
very
very
much.
much.
So much for coming.
No, that's okay, you're welcome. Thank
Couldn't
you
think
for
of
being
any
on.
suggestions quick because it was very flowed really well. It was perfect for what you were trying to educate us about.
Yeah.
It was nice to see all the
I learned
interactions.
things.
Yeah. Oh, good.
Thank you.
Good. Excellent. Just let it out. I'm going to go
Yeah, all
through
the good education components like theory and then doing things to keep you awake and engaged. So nicely
Aw.
done. Thank you.
Thank you.